A very good morning to everyone. Akhilandeshwari M. Madam is Professor, Department of Anesthesiology and Pain Medicine from Sri Ramachandra Medical College and Research Institute, Chennai. Her area of interests are obstetric anesthesia, airway and pediatric anesthesia. Chapter on airway equipments, anesthesia for high-risk pregnancy and post-LACS analgesia. She is the faculty for airway workshops in state and regional conference. Plus, Madam is reviver for JOACP and Airway Journal. Welcome, Madam.
For inviting me to this prestigious meet. Starting with the topic recent advances in gestational hypertension. When we look at the maternal mortality rate which is being presented by the CDC, public health surveillance system from USA, what we find is the cardiovascular causes are most common cause for maternal mortality even in developed countries like United States. And of those, when you look at hypertensive disorders of pregnancy, they contribute around 6.3% of mortality, and cerebrovascular accidents contribute to about another 6.1%, because most of the cerebrovascular accidents which occur during pregnancy is predominantly due to pregnancy-induced hypertension. Now, after looking at the mortality, when we look at the cardiovascular morbidity events which are occurring in preeclampsia study, this is a retrospective cohort study which was published in Anesthesia Analgesia Journal, where they have analyzed about 1,58,114 preeclampsia patients. And these patients, what were the cardiovascular events which occurred during delivery, and what were their 90 days post-operative follow-up, and was there any admission for cardiac events? These were the things that were analyzed in this study. In what they found was, women with preeclampsia had higher risk of acute cardiovascular morbidity till up to 90 days postpartum. And this was irrespective of whether the patient belonged to the category of severe preeclampsia or even preeclampsia without severe features. This was the most important thing which we have to take in mind. The next thing is, the risk was about 5 times higher compared to women who had mild preeclampsia. So, compared to healthy parturients, there was a twofold increase in ordinary people, and when severe preeclampsia was there, there was a fivefold increase in acute cardiovascular events. And when you look at the type of cardiovascular events which occurred in them, it was predominantly pulmonary edema, followed by heart failure, cerebrovascular disease and renal failure. These were the predominant causes of admission during 90 days postpartum and during the process of delivery. With this introduction, my focus is going to be about what are the recent definitions and classifications of pregnancy-induced hypertension, pathophysiology and prediction, perioperative optimization and risk stratification, and is there a role of focus in PIH patients, and what is the optimal vasopressors and nutritronics which we have to give in these subset of patients. So when we going by the definition, as per the ACOG guidelines which was released in 2020, regarding the first thing is that the new onset of hypertension which occurs after 20 weeks of gestation is the first criteria for a woman to be called as pregnancy-induced hypertension or gestational hypertension. The next thing is, the reading should be at least more than 140 by 90 millimeters of mercury, which is 4 hours apart taken. There should be 2 readings which is more than or equal to 140 by 90 millimeters of mercury. This is the second requirement. The third requirement is, suppose if the patient presents with a higher BP of systolic more than 160 millimeters or diastolic more than or equal to 110, then irrespective of we don't need to recheck the BP. A single reading is enough to classify these patients as preeclampsia. And in addition, the next requirement is presence of proteinuria. When you look at the proteinuria, it should be more than 300 milligrams for 24 hours, and protein to creatinine ratio of more than 0.3, and dipstick, when these two are not available, at least a dipstick protein should be more than 2. So though proteinuria is included as a requirement for classification of pregnancy induced hypertension, we should remember that we need not have proteinuria as a prerequisite for classifying them. Just presence of hypertension is enough to classify these patients under this category. So it is new onset of hypertension after 20 weeks of gestation, and when there is involvement of any one of these organs, then they come under the category of preeclampsia with severe features. So this shows that it is a multisystemic disorder which is due to endothelial dysfunction. So they can have manifestations relating to liver, lung and brain, or in the form of kidney, or in addition to all these things, even if intrauterine growth retardation is there along with new onset of hypertension, then these patients come under the category of preeclampsia with severe features. So proteinuria is not a prerequisite, and presence of hypertension with any one of the following features which is mentioned in the various organ system, then it comes under preeclampsia with severe features. There is no more categorization of mild, moderate in the present scenario. And what is the difference compared to the regular hypertensives? This preeclampsia is a systemic disease which is being activated due to endothelial dysfunction, and there is no linear progression of the severity of the disease. The patient can present with severe hypertension at diagnosis, and usually there can be non-responders to treatment even after giving adequate medications. This is what we have to remember, where termination of pregnancy is the only thing which is going to decrease the hypertension and its associated complications which are associated with it. So, and it has been associated with significant acute and long-term morbidity and mortality. When we look at the pathophysiology, the first thing is due to abnormal placentation, where there is inadequate cytotroph invasion. So there is decreased placental blood flow causing release of cytokines, and there is an imbalance between your angiogenic factors and anti-angiogenic factors. Ultimately, they all lead to systemic activation and cytokine activation. The next new theory is, even in pregnancy patients who are prone for preeclampsia, they have an elevated SVR and low cardiac output prior to conception. So this is the new set of patients which we have to do research and find out, where they present with even without placental abnormalities, they can have a predilection to go into preeclampsia. The next thing is mismatch between oxygen supply and demand as it occurs when obesity and diabetic people, where pregnancy starts later, where PIH starts later. So what are the biomarkers for preeclampsia is the identification of decreased placental growth factors in the second trimester of pregnancy, along with increased FLT proteins or tyrosine kinase. And looking at as we said, it is a majority of the problems are due to cardiac. Let us look at the physiology behind the cardiac thing. In addition to 4-chamber dilatation which occurs during pregnancy, these patients will have increased SVR. In addition to increased SVR, the cardiac output is normal or it is increased, and they will have minimal pericardial fluid. So it is called as ionovasoconstrictor state, where the cardiac output is normal in majority of the patients unless they go into cardiomyopathy or systolic failure. So they can present with pulmonary edema due to increased SVR causing left ventricular end diastolic pressures. So this is what is the main cardiovascular morbidity which occurs. Next subset of patient is early onset and late onset preeclampsia, where preeclampsia occurs prior to 34 weeks of gestation. These are more prone for severe preeclampsia, and they have a predilection to go into eclampsia, HELP syndrome, and neonatal morbidity is also more when it occurs prior to 34 weeks of gestation. And when we look at the cardiovascular complications, the left ventricular mass is increased, there is increased left ventricular end diastolic pressures, they are more prone for systolic and diastolic dysfunction unlike the other group, and cardiomyopathy is also more common. And when we analyze the BNP levels, it is quite high in early onset preeclampsia. So what our main aim is to prevent all these complications which are going to occur. So prediction of severity is mainly, as I said, by clinical evaluation. This should be followed by hematological assessment and biochemical tests like your liver function test, coagulations and RFT and electrolytes, and clinical scores such as the prediction model for risk of complications in early pre-onset eclampsia. This is available in the net, where it is a composite score just like your SOFA score, where the age of the patient, the presence of chest pain, dyspnea, peripheral oxygen saturation, all these when you feed into it, it will give you the risk for complications which is going to occur. So the risk can be 47%, 57%. It's very easy to tell your patient based on this. And the next method is to assess the severity. Ultrasound plays a predominant role. So when you look at the use of ultrasound, it helps in quantifying the disease severity. The presence of extravascular lung water, which is called as the pulmonary interstitial syndrome, can be identified by using ultrasound. You can detect raised intracranial pressure using optic nerve sheath diameter, and left ventricular systolic and diastolic function using your echocardiography. So one thing which is very important and everyone can learn is we can use lung ultrasound in all these patients and find out the presence of, you can see lines which are originating from the pleura extending all the way down. They are 4 to 5 in number. These are called as the lung comets. So the presence of positive B lines, which is at least 3 to 6 per image, indicate that the patient has gone into the other phase where alveolar edema has set in. So just the presence of B lines indicate interstitial edema, and the presence of 3 to 6 per image, and when the width is less than 3 millimeters apart, it indicates that the patient has gone in for alveolar edema. So absence of interstitial pulmonary edema just rules out elevated left ventricular end diastolic pressure in these patients. So this is a simple tool which will assess both your cardiac function and your lung pathology, so that you need not overload them with fluids. And the next one is optic nerve sheath diameter, which is more than 5.8 millimeter. It is diagnostic of raised ICP, and it can detect ICP even prior to the onset of papilledema, and serial examinations have been done where there are studies where magnesium sulfate has been given and they have assessed the response to it by measuring the serial diameters. So after analyzing the severity, the next step is to be, for example, there is a patient who comes with a BP of 180, 110 with headache and vomiting. The first step is, as you know, all the obstetricians will be very much interested in delivering, but prior to that we need to optimize blood pressures, because anesthesia in the presence of unoptimized blood pressure will lead to pulmonary edema and it can cause intracranial hemorrhage. These are the two complications which we have to avoid. So we should have a very high sensitivity to put invasive arterial line in these patients and start on antihypertensive drugs. Why is intracranial hemorrhage more common? The only simple reason being cerebral autoregulation is impaired, and it is because of untreated or undertreated hypertension. So management of severe preeclampsia, we have labetalol you give for 20 milligrams as the first dose. The second dose should be escalated if there is no response to 40 milligrams, and then after 5 minutes you increase it to 80 milligrams, so that a maximum dose of 300 milligrams in the first hour can be given. So that and while giving this, your target BP should be at least 140 to 150 millimeters of mercury with a diastolic of at least 90 by 100. These are the targets. If the patient cannot be given labetalol, then you can switch over to nifedipine, which is easily available, and you can give, sublingual is not advisable, give oral nifedipine 10 to 20 milligrams every 2 to 6 hours up to a maximum dose of 180 milligrams. Magnesium should not be used per se for control of blood pressures. It is only indicated with severe preeclampsia who have imminent signs or headache and visual disturbances to control the cerebral edema. So supportive treatment for eclampsia should always be given. You secure your IV access, and magnesium sulfate is recommended IV or IM in all these patients to prevent seizures and not for control of blood pressures. If magnesium sulfate is being given and if the patient is being wheeled into the OT, make sure that it is labeled, because inadvertently if large amounts of magnesium are infused, then the patient will have features of toxicity as soon as you induce, and the reason for arrest would not be known, because we are not regularly monitoring serum magnesium levels in these patients. And as you know, I don't think all of us are monitoring even deep tendon reflexes, because hardly there is any time. Always the thing is to increase the delivery time. So, and neuraxial anesthesia is preferred for all these advantages which everyone knows. And the risk for epidural hematoma is this slide we have to focus, where if your count is more than 70,000, a single shot spinal is indicated in all these patients. When the count is between 50 to 70,000 and you have a very high risk for difficult airway, then weigh the risk benefit ratio, and even then you can go ahead and give a single shot spinal anesthesia, whereas continuous infusions are not recommended. For platelets less than 50,000, it is advisable not to give neuraxial blockade even with platelet transfusions, because that indicates there is a dynamic destruction and it can cause epidural hematoma. And what are the contraindications for regional anesthesia? It is usually acute pulmonary edema and eclampsia with altered mentation and dynamic coagulopathic status such as your abruption. So, one thing which we have to remember when we are giving GA in these patients is, apart from the anatomical features, these patients are physiologically difficult airway because they have interstitial pulmonary edema. So, they have difficult airway at all levels and during intubation. So, every effort should be made to prevent desaturation, which is done by stepwise approach, where you pre-oxygenation is mandatory, and you have to manually ventilate these patients with 15 to 20 centimeters of water so that interstitial pulmonary edema is reduced, and use of drugs to attenuate hemodynamic response. Fentanyl about 50 micrograms and esmolol 1 to 2 milligram per kg, and in combination with Xylacard is recommended so that there is no interstitial pulmonary edema. The second thing is, always restrict your fluids to less than 80 ml per hour, inclusive of your magnesium sulfate and your other infusion. And vasopressors, phenylephrine is recommended provided there is no systolic failure in these patients. That is the first choice of vasopressor. And regarding uterotonics, what we have to remember is, these patients, they have found out that the ED90 dose which is required to maintain tonicity is roughly about 10 times higher, like 24.9 international units per hour is recommended, because these patients are all on magnesium and they have a high degree of risk for postpartum hemorrhage. So, take home points are: assessment and optimization of BP prior to operative delivery and during initiation of epidural analgesia. Invasive arterial line is recommended in all these patients. POCUS, especially lung ultrasound, is a useful tool and we have to use it on every patient. And GA is an art and PIH, and it should be based on scientific principles. Thank you.